Okay, I'd like to introduce you to Lecture 8, which is Chapter 8 on articulations. And now we're going to look at the whole idea of how the skeletal system works, and eventually we will lead into muscle function and see how it interacts with our. So when we look at articulations, articulation is nothing more than another name for a joint. And we're going to see that there's various roles to articulations. Some articulations are there to fuse bones together, like a suture, and in some cases you won't see these suture lines in the adults. We can basically turn several bones into one. Others allow movement or allow either free movement or restrictive movement between two bones. And others, like the Gomphosis, where you find in your teeth, are just basically uh, um, attachment points that between like teeth and bone and other structures. So what is an articulation? It's technically a site where two bones meet, and the function is to give the skeleton mobility or to hold the skeleton together, like we just mentioned earlier, looking at the three examples. The way we classify joints, and this is going to be your biggest problem, is because there's a couple of ways to classify joints. For the most commonly used way that we're going to use in this book is we're going to base it on the amount of movement that's allowed by that joint. So we're going to see that there are three generally functional movement categories. There are what are called totally movable joints called synarthroses, and the term syn basically means to hold together, to bind together. So synarthroses are immovable. It means it's mostly an attachment point to connect bones. There's going to be the amphiarthroses. Amphi means kind of both, and this is going to give us limited movement or slight movement. And sometimes these are areas that allow rotation, bones to glide past each other or to rotate around each other, but not necessarily have the bones do a lot of movement. And then there's the diarthroses, which is the very common one we study in this class. And these allow free movement. And these are going to usually be associated with joints called synovial joints. They're very complex, and we'll see these particularly in the shoulder, the hip, the wrists, and the ankle joints, and also partially in the elbow joint. We could also look at joints from their structural classification. And kind of what we do is we take the functional classification, blend it with the structural classification to come up with a joint, to come up with complex names. But just be aware that there's two ways to classify. Structurally, it means what is that joint made of, and then what type of joint does that joint, or what type of movement does that joint allow. So we're going to see there are also three structural classifications, what are called fibrous joints. And as it says, this is a connective tissue fiber that holds them together. And typically these can allow an amphiarthrosis type of movement, and not always. Sometimes they're a stable unit. We have cartilaginous joints, which could also allow a mild movement, but also could be something that attaches bones together tightly. We see that these are more associated with compression, bones that compress on each other. And the same could be true for fibers too. These are sometimes interwoven. And then the freely movable joints or synovial joints are very complex, and we're going to see that they're an organ in themselves. So joints are basically organs that work together with bone and other tissues to support the body, glue the body together, and carry out movement. So let us first look at the anatomical or classification of joints. That means, what are they made of? What is their connective tissue? So we're going to look at what's called the fibrous joints. And these joints typically have little or no joint cavity. That means the bones are literally almost in touch with each other. And if they're not in touch with each other, there's a fibrous material, collagen mixture material in there. Most of these are going to be synarthrosis. That means immovable. These are solid attachment points. Some examples are going to be sutures, which you do have to recognize in class. Syndesmoses, which are a little more rare. I mean, we'll see them, but I'm not going to ask you to really point these out. but you will be able to recognize them. And then what are called Gomphosis. Gomph come from the term tooth. And this is just important to know when you get to digestive system, and even today with the bone. Gomphosis hold teeth in place. And this is a very problematic joint because it's the only joint that's really exposed to the environment and subject to damage. A lot of damage, particularly bacterial damage. So let us look at what a suture is. A suture usually allows interlocking of bones. Sutures could be very large in young children, so they do allow for growth. It's almost like an epiphysis connection. So these sutures allow for growth, but in an adult, usually they ossify and the fibrous part becomes sometimes non-existent or not present at all. Now you do want a little because it does allow for some flexibility and give during damage, but typically after middle age they ossify, and it makes these joints more subject to fractures and breaking, like for example the hip joint in older people are more subject to breaking because of that. So what is a suture? The most prominent ones are in the skull. These are still visible. They remain this way for a long period of time with the fibrous cartilage in there because we want flexibility. You want your skull to be able to be hit and that suture compress, okay, without causing damage or much damage to the bone. I mean, damage will occur, but not as much without those sutures. And notice the interlocking. It evolves like a cantilever type effect so that this bone can rock a little within that cavity and have some give. And then there's, under the fibrous joint, syndesmoses. Okay, these are a little more complex to explain than a suture, but these are bands of thicker fibrous tissue that allow slight mobility, not enough to be called a mobile joint. But what these are is they try to hold two bones together fast, but do give some slight mobility in that attachment. And the classic example we'll see is in the radius and ulnar, which right there at the and that actually is not the radius and the ulnar. That's also in the tibia and the fibula. So we can see the attachment there allows the tibia and the fibula to be lined up perfectly and straight and not detached, but it also allows this to basically rotate a little as we're walking. And in the radius and the ulnar allows a little more rotation. So it allows us this to be fixed and the proximal part to be able to rock back and forth a little without detachment. Then we have what's called the peg and socket joint or the Gomphosis. In us, it's mostly found in a tooth. If you're a deer or an antelope, it's found in the bony horn. Okay, so this is the joint. And guys, when you start getting gum disease and severe periodontitis, what you're doing is get inflammation of that joint because bacteria could eat it up. It's very high in protein. And also fungi could eat that too. So when we start talking about teeth falling out, it means that that joint was eaten. And that joint does tend to decay with age. In our temporary teeth, the baby's teeth, that joint is very weak. And then what happens is the tooth underneath it literally grows underneath and pushes that up, and this in the baby teeth immediately just falls out. And this is why kids can sometimes pull their baby teeth out with their hands, particularly when there's a little pressure from the adult tooth coming in. So in the adult tooth, the Gomphosis is much tougher than in the juvenile teeth. Now we get into the cartilaginous joints, okay, and these again are united by a cartilage, and some examples of synchondroses, symphyses. We're not going to look at this too much, except I do want you to know a couple of major symphyses. We'll just look at a okay, so when we look at the synchondroses, and don't lose sleep over them, it's like a hyaline cartilage type cartilage, okay, and you can see here it's in the epiphyseal plate. That's the common one, and I'm not going to really ask you this. This is a difficult one, and you also find it between the first rib and the manubrium and the sternum. But this is the one, if anything, that is important to know. But synchondrosis just means it holds like cartilage together. It's a joint that holds cartilage next to bone. I mean, that's the joint right there. That's the joint right there. The symphysis is probably more important. This is kind of a little, how can I put this, a little larger than a synchondrosis and a little bigger, and it allows more of an amphiarthrosis movement. So, and we see this particularly, the important one particularly is the pubic symphysis, because this joint can actually change its consistency, like particularly in pregnant women right before delivery. Okay, this thing kind of softens up and allows a little more stretching and rocking of the pelvic cavity. Over time, sometimes this also loses its integrity and can make the hip more susceptible to fracture. The other symphysis is found in the hyoid cartilage between the vertebrae, what we call the intervertebral disc area. And actually, guys, there's about 2 to 3 joints that make this up. So just know that there is a symphysis in the vertebral column, but there's also other joints that assist it. It's a very complex joint, and the hyoid cartilage here does allow for flexibility, limited movement, but it also acts as a cushion, and it's very important. Now we're going to get to the synovial joints. These are the hardest category, mostly because of their complexity. They are the true organ of the joint world, because we're going to see they are very complicated, and they're also the joint that's probably more subject to any other damage, particularly arthritis. And I've seen this in many animals. These joints tend to wear out with time, and particularly systemic bacterial infections like rheumatoid arthritis, other types of blood infections will affect these joints. They're very subject also to autoimmunity diseases. Okay, so when we look at the distinguishing feature of these, is they have an articular surface, hyaline cartilage, which covers the bones, usually the epiphyses of the bone, or what's called the articular surface of the bone in non-long bones. There's the joint itself, called the synovial joint, which is the cavity. It's a hollow cavity, and we're going to see that it's actually filled with a fluid a little later. Okay, there's the articular joint capsule. That means this is a fiber, an irregular, dense fibrous material that surrounds the whole joint in itself. It's a protector of the joint. So it keeps it all cupped in, keeps the bones together, it keeps the cavity intact. And then there's a synovial fluid, and you'll see all of this. And this is a fluid made of hyaluronic acid. It's a sugary compound, okay, that is kind of sticky, but also kind of like a lubricant. And it's funny, hyaluronic acid is used in makeups as like lanolin. So it's a very unusual type of compound. And it is continuously produced by the joint, except as you get older. And it is also subject to infection. It does come out of the plasma. It's a filtrate from the plasma. It's produced by special cells. And again, it's for lubricant and also cushioning. As you get older, the synovial fluid decreases and the body tends to get smaller. And what happens sometimes is the joint surfaces tend to rub. And I'll show you that when we look at their structure. So this is a theoretical bone, or 2 bones. We don't really have a joint that looks like that. Okay. And so this is showing the synovium. And again, you do find these particularly in the appendages, and you will find this between the phalanges, between the metacarpals and the phalanges. So this is a pretty common joint. So there's the bony structure. You can see in this case, that's your epiphyses. This is the articular surface right here and right here. Okay, and then you got your synovial space. And then you have the synovial fluid in there in like a sac. So there's a membrane there. It's a serous type membrane responsible for the maintenance and introduction of the synovial fluid. And then you have a joint capsule around that, covering literally that whole area like that, tightly adhered to the periosteum. And this is a site for healing too. Now understand, cartilage, ligaments, tendons, whatever, all of these are slow healing tissues. They have very small blood supply, a very few fibroblasts, so it does take them time to heal, and sometimes the only way to get them to heal is to surgically correct them or sometimes replace them with artificial material. So over here, part of the articular fibrous capsule. You're also going to see sometimes they're connected to ligaments. Ligaments meaning a bone-to-bone attachment, and you're also going to find them sometimes attached to muscle, where the muscle will attach right about here and sometimes here and brace that movement against not just the capsule, not too much of the capsule, but usually against the bone. So, synovial joints also have what's called accessory structures, and sometimes you're born with these, sometimes these actually form, okay, during excessive or extraordinary usage. So one term you hear a lot with the disease bursitis are these sacs called bursae. Think of them as being a synovial sac without the joint. It's the same structure, except it doesn't have a joint. They form in other places. They form for a variety of regions, but they are synovial fluid sacs. They could be flat. They could be round. They usually take on the shape of where they are, and they act like ball bearings. They also act as like lever points that take the pressure off of bone rubbing against other tissue, or tendons rubbing against bone, or tendon rubbing against tendon, or ligament rubbing against something. So you usually find these sometimes between ligaments, and you'll see an example of this in a minute. So here we're looking at the coracoid. This is actually your scapula, and this is the head of your humerus. And what happens is you have this incredible muscle attachment and also some ligaments, okay, and tendons that come across here, okay. And what happens if you didn't, what happens is this will rub against the bone. If that bursa was not there, so the bursa is slimy, it gives in, it kind of rocks back and forth. It moves a little, it gives, it is held in place in tissue, but it gives a little, okay, and allows this to rock back and forth without rubbing into the articular surface of the bone. So this is an incredible joint when you think about it. And this is showing again a little more part of the movement. Notice how it rocks. It rolls and rocks and sways, almost like having a balloon, a partially inflated balloon between your hands, and you rock it back and forth, but you can only rock it so far. So guys, when too much activity is going on in this area, for example, in tennis players, particularly with this joint, or pitchers, this constant rubbing can cause this sac to inflame. And man, what that does is it puts pressure on the muscle attachment, the ligaments, also, and any surrounding tissue, and causes pain. But most of the pain is actually not the bursa itself, but it's the surrounding soft tissue, the tendons and the ligaments, and sometimes the muscle, particularly if it affects muscle movement. Now, there's also something called a tendon sheath. It is a bursa that, instead of being a little bubble, it's a long tube that wraps around itself and covers a whole long area. So it could actually wrap around a tendon in itself, or it could wrap around a ligament, usually a tendon, because tendons are movable. Okay, so these are incredibly complex, and they're an extra barrier, but particularly they're a cushion for muscle movement. When you have this tendon that pulls back and forth, you don't want it rubbing directly against that bone, and it acts like a little lubricating effect. Tendon sheets do inflame, particularly those we find in the wrist and the hand with repetitive movements. So any type of extreme repetitive movement or banging on these, or like jackhammer type movements, cause inflation of these. And these can sometimes form spontaneously in certain areas to make up for it, for any type of extreme movement. So that's the structure of a joint. Now, when we explain movement, this becomes another problem, and I think we're getting the idea that there's a lot of stuff that causes problems in this class. So now let's look at joint movement, the range of movement. So, and within the range of movement, we're going to see that there's sub-movements. So when we look at synovial joints, the range of movement of a joint, this is only in movable joints, could be what's called non-axial. That means it's a slipping movement only, back and forth, slipping movement. Okay, we have uniaxial, and we'll see what these look like, in which the movement is only one plane. We're going to see what's called biaxial, okay, in which the movement is going to be in two planes. We'll see this. That means like transverse, longitudinal. And multi-axial is going to be more of they move around in all three planes of movement. I think of the planes as being the XY axis. And again, just talking about it doesn't show you it. So we're going to look at these a little, okay, and work them into the rest of our discussion. So when we look at the movement of synovial joints, these multi-axial, whatever, non-axial, these all fit into the terminology of the basic synovial joint movements. And again, let's not worry so much about what we looked at in the previous slide, but I just want to show you how that terminology fits into this, because joints are very complex, and a lot of them have simple movements, very complex movements that we can subcategorize. So there's going to be what are called gliding synovial joints, angular movement joints, and this is where we start getting into what degree of angular motion, so we have what is called flexion, extension, and hyperextension, abduction, adduction. Ab always means away, like I am abnormal. Add means to come towards, like to add numbers together, to put them together. Circum means you move in a circle. Okay, and that's different than a rotation. You'll see a circle actually means the bone is moving like that. It's moving in an actual circle. There's your bone right there, kind of actually being moved. And then there's what are called rotations. Rotation, that means the bone is being twisted in place. And we'll see where these occur, or at least part of the bone is being twisted in place. Okay, and these are to be what are called special movements. And these are very unique joints that are limited to one particular body part or a couple of particular body parts. So we're going to have what's called supination and pronation. We're going to see this is typically found in the hand. The foot doesn't do it well. Dorsiflexion and plantarflexion. Dorsi means the top of your foot. Plantar means the bottom of your foot, which remember the bottom of your foot is anterior. The top of your foot is dorsal. This is where you start to see that. So your anatomical position is you're standing on your heels with your toes almost touching your leg. There's to be inversion, eversion. And guys, and sometimes the appendages have two different types of movements depending on the muscle groups moving them and the joints that are involved and the type of movement on that joint. We're going to see protraction, retraction. This is to be very typical, associated with the lower jaw, your mandible. Elevation, depression, also possible with the mandible, and also possible with the scapula and clavicle. Opposition, we're going to see this mostly in your thumb. So when we look at gliding movements, and gliding movements are going to be uniaxial, biaxial, and I'm not going to worry so much about the axial types. These are the terms we're mostly going to go with. So understand what a gliding joint is, and at least one example. So gliding joints can occur where flat bone surfaces glide over another. Okay, they could also be found in irregular bones. Okay, some examples we're going to see are going to be the intercarpal joints, intertarsal joints, and between articular surfaces of the vertebrae. So it allows, okay, a little glide. That means kind of one direction or in and out, back and forth, depending on the structure of that joint. So your vertebral column, the gliding is probably going to be more towards a forwards back rather than a side to side, because with the side to side, you need to get more of a bending of that joint, not so much a glide. So here's a typical gliding motion. Notice what's happening here is these bones are gliding one direction back and forth. When you move your hand from side to side, the royalty wave, you're not rocking your arm, you're just rocking your hand. That's a gliding motion. Just memorize it. That's it. So just kind of wave, do a hand wave. Don't move your forearm, just move your wrist back and forth. This is a gliding motion. And this joint tends to get inflamed a lot with repetitive motion in people in certain occupations. So the angular movement is going to be a little more difficult to explain because you have to first put the person in an anatomical position and look at how these joints, you know, respond to sagittal movement and also frontal movement. What are they doing compared to the axis of the body? So you have to look at the person from the anatomical position, arms by the sides, legs straight together, and then how is this movement relating to the axis of the body? So with flexion, we're going to see that the joint that's being flexed is going to be decreased in angle. That means going from straight to as tight as you can get it. With extension, we're going to increase the angle, and this is going to make that the joint spread out. And then there's something called hyperextension, which some people can do naturally in a lot of their synovial joints, and not always people always can. But this is when the joint goes beyond the anatomical position, and this is found sometimes in the arm, sometimes in the leg, a lot in the fingers, because this is more essential for fingers. So some joints do this naturally, others don't. It depends on the configuration of the articular surface. So when we look at the angular motion, flexion and extension, your head in the anatomical position is straight up. When we look at flexion, okay, your anatomical position now, the anterior is going to be the decrease in angle. So watch this. So when the head moves forward, the angle here, this angle is getting smaller. It goes from 180 degrees to here, that's going to be like, 120 degrees. And you can get your head all the way down to almost 90 if she was able, she has multiple heads, if she was able to get her head down here. So that's flexion. Extension is when the head is literally, and this is kind of weird, is slightly erect. I mean, it's upright. And then there's hyperextension. So this is one of the few times when in anatomical position you say you're actually at full extension. And then you have hyperextension, which means now I'm going away from the body plane again, but the angle, this angle, let me do that in blue. This angle is now bent this way. And from 180, we now have about 220 degree angle. Here's another example of flexion, extension, and hyperextension between the sacrum and your lumbar vertebrae, right about here. So flexion, angle from anatomical position is getting less. We measure that angle. And then with hyperextension, we're measuring this angle. So this is one to know. In the appendages, flexion and extension. So again, we got to pay attention to anatomical position. When you're moving towards the front, you're decreasing that angle. So for the arm, normally for the upper arm, shoulder, actually we call this, okay, for the movement. So that's your 0 point, okay, your 180. What we'll do is we're flexing, and actually you're flexing it, so you're making actually this angle of the plane, that's your plane, smaller. And with this, if you go this way, you're extending it. So flexion just means you're moving arms forward. The degree between your nose and your arm is decreasing, versus if you move it back like here, that angle is decreasing. And then we can look at flexion and extension of the lower leg. That's obviously flexion. You're going away from the anatomical position and decreasing that joint. And then extension is basically moving it forward to your resting position. And your resting position could also be called extended. So when they say extend your leg, it doesn't mean to hyperextend and put it there. Some more angular movements. We have abduction, which you move away from the sagittal midline, and adduction, when you return a body to the anatomical position and sagittal midline. And then there's what's called circumduction, which we're going to see actually the muscles that do that is doing an abduction and flexion together at the same time, or an extension and adduction together at the same time. So this is a much more complex movement, and I'll show you in a minute. So when we look at abduction, notice her hand, anatomical position. So the resting position is your adduction. Ad means to towards the body axis. There's her axis. Woo! Okay, we lost that. There's her axis. A little crooked, but there's her axis. So adduction means you're moving towards the axis. Hands staying forward. Abduction means you're moving away, and you can abduct all the way up there, okay, and increase that angle to as much as you can, because it's the angle from here to there. So that's adduction. Now with circumduction, now notice this, you're rotating, and that's a bad term to use, but you're circling your hand, so your hand is moving without this is actually turning in a circle, but this is moving so that your thumb is traveling in a path. And if you do this, just rotate your shoulder, your hands not changing position as much as just going back and forth, back and forth. You'll see that it's moving in like a semicircle, and you can't go all the way around. But when you move your hand in a semicircle, that is called circumduction. And just practice that, and we'll show this one in class. Now here's rotation. Now notice with rotation, you're moving on an axis. That means the bone is not changing position except in a circle. So the best way to see this is when you rotate your head. Your head is not swinging around like your hand. It's just moving in place. You can hold your finger on your throat as you're doing this, and the head's going to be the same way. And the same is true, you can do this with your foot. As long as your foot is flat, you can rotate that joint right there. And you can do partial rotations between your vertebral column. And we do have other rotation areas throughout the body, but the most common one is the head. If you're going to give that as an example, let's say on a practical. Now we get into the whole idea of these special movements, supination and pronation. Now notice how, now this is to be a little different than your circumduction, even though that is doing a little supination and pronation. Sometimes these movements work together. So in supination and pronation, okay, what you're doing is your pronation. Prone means your back, your dorsal side. So that's the dorsal part of your hand. It just means I can see the dorsal part of your hand. So the best way to do this type of movement, because you'll see it is actually a rotation, not a circumduction. Circumduction, to get a circumduction, put your hands by your side and move the elbow joint to get your hands to face forward, face back. Now this one, you bend your elbows, brace your arms by the side of your hand and bend your elbows to a 90-degree angle. Then what you do is now you rotate. You can see they're in the same plane. Your middle finger is not moving, but your hands, when the palms are up, are supinating. When your hands are down, are pronating. So these movements serve different potentials based on interaction between other joints. And in this joint, you're not at anatomical position. Your elbows are bent. They're flexed to the halfway flexion point. And then some other special movements are dorsiflexion, plantarflexion. This is not a natural movement for people unless they're climbing steps, or just generally walking, particularly with heels. So dorsiflexion, your foot is at the anatomical position, and what you do is you rock your foot up, so you're standing on your heel, or you put your foot down, so you're standing on your toes. So what happens is that you're flexing. That means flexing means you're moving your dorsal side to a smaller angle to the body. So you're showing, here's your dorsal part of your foot. Yes, it's kind of backwards in a way. And then your plantar side, you're moving that down. Okay, you're kind of flexing that angle too, because you're shortening that angle from where it normally is. This is the normal angle for you to stand, and now you're decreasing that angle like that. And then under special movements too, we have inversion, eversion, and again, this you're going to have to see. This is more of a side-to-side movement. This one we don't actually do too often. And sometimes if we do it, that causes a strain. And it's funny because the muscles that do this tend to be very weak muscles down in the calf area. So inversion, eversion, okay, you're just rocking the foot either towards the interior of the body or the exterior. So this is the lateral side. This is medial. That's lateral. So there's your fibula would be here, your tibia. Okay, and this is an inversion. In means you're bringing it in towards the medial part of the body. Eversion means you're bringing it away from your axis to the lateral part of the body. So just practice these on your colleagues. Get to know them, get to love them. More special movements. You're getting tired of this, I know. Protraction, retraction. Classic example is the jaw, and I call this the funny face one. It's like, I'm going to kill you or I'm surprised by you, what you just said. So protraction, this is typically of the mandible. You're bringing the mandible forward so that your lower jaw is beyond your upper jaw. Retraction is when you bring your mandible back, your lower jaw, and your upper jaw overhangs your lower jaw. These are part of used for vocalization, for movement, during the chewing of food, for swallowing, and also for just facial entertainment. Then we have what's called elevation depression. Elevation obviously means you're moving up superiorly. Depression means inferiorly, away from the head. That's your reference. So let us look at elevation and depression. So with elevation, your jaw is locked tight. This is pulled up. This is not a side to side or forward back motion. This is totally up. When you're depressing the mandible, notice we have to say the mandible. You have to name the bones, so we know, because in the shoulders can be an issue. We're talking about elevation depression. So we're pulling down on the mandible, and that's opening the mouth. So this is involved in vocalization, in chewing, and also in emotion, like, I can't believe you said that. Okay, so again, elevation depression. Elevation, you're bringing it up towards the head. You're moving it away towards the head. Your head is your reference. And then opposition. This is where, because you have opposable thumb, a thumb that can rock around freely and not just bend like your other hands, just in one plane. Your thumb can do 2 planes. So opposition means you take your thumb and you oppose it to any of your other fingers. It doesn't have to be your first finger. And you could even touch your thumb to your palm. That's all opposition. It means I'm taking my thumb and totally making it opposite to the palmar region of your hand, the anterior region of your hand. So to finish off, we're going to finish up with the synovial joints. So when we look at synovial joints, and I'm not going to get into a lot of detail with this, I just want you to know the basic, movable, immovable, what are these terms, and recognize one. But when we look at the synovial joints, now we look at the shape of the joint and its movement to describe what it does. And guys, this is why joints are ridiculous to study, because I don't know, a lot of people came up with the movement of the joints depending on what they were looking at, anatomists versus medical doctors versus, whatever. So this is a bucket load of terminology that overlaps. But with the synovial joints, we have what are called planes, hinges. This is an important one because this is one you'll find in your elbow. Pivots. This is an important one because we'll see that this allows rotation of the head. So these joints are actually what gives you those body movements you saw. Flexion, extension, blah, blah, blah. There's the condyloid, the saddle. We won't see that one too often. The most important ones we'll see are the ball and socket. These are the bigger ones that we see allow appendage movement, particularly the ball and socket. So a plane joint moves in a plane, and this is basically biaxial. You can see that. One axis, 2. It's a flat movement. So again, your wrist, we covered this already. Okay. Here's a hinge. Elbows, classic. A hinge means you allow a flexion with the resultant extension along one plane. Okay, so what you do is you rock this up and down. So think of a hinge joint is this very simple flexion, extension. Pivot joint, this is a little more difficult one. This allows you to pivot. This is your what's called your ulnar. This is your radius. What this allows to do is you can totally rotate, and in some cases circumduct the radius. So what you do is you rotate the radius, but you can circumduct the hand with this one, or rotate the hand depending on the angle of this movement. So this is a classic example, the pivot. And then there's a condyloid. The condyloid allows almost a biaxial rocking movement rather than gliding. And this is very typical of your finger joints. They can some of them are braced to allow only a uni-axial position, but just bring your fingers, close your fingers, open your fingers. This is what you're looking at. This type of movement, particularly between your phalanges, okay, and your fingers. You'll see this. Your phalanges and your carpals, your metacarpals, I should say. So that's your metacarpal, your phalanges. You see that movement. And again, in all your phalanges. So this is what allows you to close your hand. It's kind of like a little depression type joint. Then we have a saddle joint. Don't confuse this with the hinge. The saddle is actually like a bone sitting in a saddle. So there's one leg, there's the other, and you got the little stirrups over there. This is a weird joint that we find mostly in the wrist and also in the ankles. So just know it's there. This is a joint I probably will not pick out for you to answer questions on. Now this one I will. The ball and socket. Now guys, this is different from any of the other joints you saw. This is allowing totally free movement, not just uniaxial, whatever. So this is allowing a movement, a multi-axial unit. Now notice the cup here is much deeper than we've seen before. This is actually a deep socket, not a shallow depression. And this movement is not going to just be, rocking back and forth. It could be actual twisting in there. So this is going to allow multi-plane movement. The shoulder joint, an example, and the hip joint is a classic example of this. So these are the joints, guys. The major ones that we need to know, we will discuss in class, and basically you'll practice in class for the test and for the practical.